Because if you go to big clinics in US, that's the Mayo Clinic in Rochester, all their cancer clinics, the fives, they are meeting virtually every morning at 9 o'clock to discuss today's patient. They have feedback from each other, and they try to push the treatment as far out from the centrum as possible. If you go to Mr. J. Parkinson, I mix the service of an old-time, small-town doctor with the latest technology to keep you and your bank account healthy. So he is taking information from patient and give them answers on the net. There was a Norwegian doctor trying to do this 5 years ago, and the Medical Association said that if you see one patient on the net, we will take away your license forever. They won't say that today. It's been much more accepted. And when we do research, these doctors say that it's fairly easy to answer this question, because they can say, one big group is, I can't answer you, you have to come to my office. The other is I can give you advice on the net. This is in Norwegian only, but just to see how the Salvation Army is working in Norway. They have a special call center for youth that are thinking in the direction of doing suicide. And they have this, you can write to them, you can SMS them, and they answer back on the SMS. This is what you probably have heard about. The Minute Clinic is from US, where they have replaced the doctors with nurses, with practicing nurses in a emergency department for the 50th most usual diseases: pain in the ear, pain in the head, pain in the lower back, and they're linked backwards through video conferencing to medical specialists. And in that way, they are able to treat patients at a lower level, at a lower cost, lower waiting list, more satisfied patient. And they're doing that in US, and they are very, very strict on the jurisdiction. And then these things are coming over us, the Google Health and the Health Vault. I do not quite understand how that will lead us, but what I do see is that while we are discussing what kind of electronic patient journal should we use, we are giving as patient the option that we can put it on Google, we can put it on Microsoft if you like. So then without innovation we end up with making potato chips instead of microchips. So what we are doing in the future is very, very difficult to say, but I think we see the direction, so to speak. And I'm going to end up with talking about what I said, the innovation-based research we are doing. And what we are doing is to try to see all the sensor-based system. We are not making any sensors ourselves. They are coming from the sky every day. Combine it with decision support system from the computer. Like I'm partly blind of words. So when I have this word program, it's very beautiful to me because it's telling me, you're wrong, you have to correct, you have to correct. You can put a X-ray through that, and the X-rays give you back an answer with a probability. And see how you can support it, cooperative computer cooperative work. And because we think that to prevent people from become sick is very, very important. And those who have become sick, we have to keep them out of the healthcare institution. But once again, it's difficult to have a hospital manager to say that my biggest aim is to prevent people from coming into the hospital. But one example. This is a girl with diabetes. She takes her blood sugar level, is linked to the mobile phone. The mobile phone sends the messages to the parents 10 times a day so the parents can see how the level is or should be. Another thing is now that we are linking this for the diabetes 2, the elderly. We are linking that with a step counter so that you have the blood sugar level and you have a feedback on how physical active you have been today. And we're also linking that with advices, all of this on the mobile phone, on how to eat. How should you eat? And when you have these 3 measurements, we think that the patient are able to see how to eat properly, how the blood sugar level could be, and how your physical activities should be. And in that way, we are very much according to what our new Minister of Health is saying. He's saying that if you have diabetes, you are told you have diabetes and you are told goodbye. The next time the hospital or the healthcare system see you is when you come back 20 years from now. because then you need dialysis, then you need laser treatment in your eyes, and we can't afford that anymore. So I want to put the money out of the hospital not to treat the complication. I want to prevent the complication to come. That is a long-term plan in Norway. Another project that we are doing is melanoma, that is skin diseases, malignant skin diseases. And we are replacing this big, expensive equipment with a pocket dermatoscope. And we link that to a PC program, and the PC program come out and do the borders like that. And then saying once again with a probability of 92%, 95%, 100% that this is malignant or benignant. That is at least the aim we have. And there is 40,000 new cases of malignant melanoma in Australia every year. So we want to link that once again to the mobile phone and give the patient the possibility to take care of themselves. Another great project, that is not a project of ours, but that is, we call it televarf, and that is patient with risk of blood clot. That could be blood clot in the brain, or it could be blood clot in the heart. What we have found is that if you train the patient, and you give the patient the responsibility to level the medicine themselves, the death rate is reduced with 30%. Or put it the other way around. If you take the doctor out of the loop, the number of patients who survive is increased with 30%. That could be a little bit provocative, but I can say so because I'm a doctor myself. It's not surprising me because these are people at our age, well educated, we know a lot of these things on our own. So we take care. We are responsible. We are also working with healthcare at home, where we have developed a video conference based on the remote control of the TV of the elderly. And in this way, they have group-based training, patient with COPD, patient with diabetes, or patient with the individual follow-up. And we do know from Norway that if you take a group of patients between 60 and 80 years old, as much as half of them are readmitted to the hospital within the next 3 days after being sent out. So the idea is that could we get somebody to lend them this video conferencing equipment, and then the hospital will call back 10 o'clock, at 4 o'clock and say, how are you? How do you do? Did you forget to answer? Did you forget to ask some of the questions when you were leaving and so on? And I'm convinced that the admitting range will go down like this.